I'll describe the basic technique of endoscopy, upper GI endoscopy. So before starting endoscopy, they ensure that the position of the patient is usually left lateral. But as I am a surgeon, sometimes we have to do endoscopy in the supine position in the operation theatre or even in the ICU also. So usually the office setup, we do endoscopy on the left lateral position. So this is a dummy. You can see the patient is the left lateral, and there is a mouth guard. I think there is a mouth guard there, and the chin is just extended and make the neck is quite straightened. That will make easy to intubate the endoscope more easily. So before starting, the neutral position should be there. The scope should be held like that, and the thumb will be on the big wheel and slightly down. That will make this endoscopic tip slightly bent. We can remind that when we want to vomit, we use our hand, our finger just like bend and introduce it. That's how you can reach in the root of the tongue, and that will induce the vomiting responses. So before starting the endoscopy, that is the neutral position, no loop, and you can see how to hold this control panel with the left hand, and with the right hand you will hold the scope on 20 centimeter mark here. And I mention this again, that we will slightly down and make the tip of the flexible endoscope, the bending portion, slightly bend, and I will introduce it. When I introduce it, we must follow the rule that the tongue should be on the 12 o'clock position, that is on the top. And then I introduce it, and we can see there is a vocal cord, there is a right pharyngeal pouch and left pharyngeal pouch. We usually introduce to the left side, that will be more comfortable for the patient. And introduce, you can see the esophagus here. We go to the esophagus and we push it. We place our hand and on the 60 mark. When you push it, you can see there is a Z line here. So the esophagus is, and that is the end of the esophagus, starting in the stomach. When you enter in the stomach, one thing you can remind that there is two directions, the direction of fundus and direction of answer. We have to complete our endoscopy, the upper GI. We have to rotate our scope like that. You see, we rotate our scope like that. So that's why we go towards the direction of antron. You can see the antral orifice. On that position, if we bend the big wheel marks, then that is the retroflexion movement. You see, very easy. When you see the antral or the pyloric orifice, then you do more bending. It is the incisor angularis, and you slightly rotate the scope, and you can easily examine the whole stomach, including the fundus, just below upwards. So we make the position neutral on the antral area, then push forward, and we just reach in the duodenum. So after reaching the duodenum, it's very important. Fix the position, inflate with air. In the human body, it's very important because that area naturally get collapsed. So you have to inflate it. Then the movement is that the big wheel down and the small wheel rotate against it, and the hand will be turned on that direction. So you can see you can easily reach the second part of the duodenum. So we reach the second part of the duodenum. So when we back, we slightly re-examine the area, because we have to sometimes when we do intubate, some lesion may miss. So when we back, then we have to carefully check the stomach at least for 5 to 6 minutes. That is the standard for upper scope examination. Some examiner are quite hurry because they introduce it and they remove it so quickly that actually cause missing of upper GI lesion very frequent. Thank you.